different. And now we have Dr. Vikas Menon with us, and he'll be talking on pigmented tumors of the ocular surface. May I request Dr. Honavar to please join us on the stage, as it suits him.
Okay. Good afternoon, everyone.
Dr. Santosh is the chair of the
from
instruction
the whites
groups.
and the pinks and the reds, now we move on to the black. Now, normally we have in the conjunctival anatomy, as a normal conjunctival anatomy, we have a lot of melanocytes as in the basal layer of epithelium, but they are far outnumbered by the epithelial cells. So that's why you don't see pigmentation as prominent. But then there are situations where either the pigment production is increased by these melanocytes or there is an abnormal proliferation of these melanocytes, and that is where you start seeing these pigment discolorations or various types of lesions. To understand about these pigmented lesions of the conjunctiva, it is best to try to think of them in either of these three categories, either benign, which are safe and the best types to have, which may be nevi or complexion associated melanosis or racial melanosis as it was called earlier, or there may be lesions which can have a significant risk of progression to melanoma, and the number third is the malignant form, which is the melanoma. So whenever you see a pigmented lesion, the question that one needs to answer in mind is whether it's one of these three, or it's a safe one basically, or is it a dangerous one. So let us see a few examples of how we can differentiate one from the other clinically. Now, who will tell me what is this? This patient presented with a bilateral diffuse pigmentation of the bulbar conjunctiva, more concentrated around the limbus and extending up to the just short of fornices on all sides. So anyone, what is this? What does this look like? Yeah, so this is complexion associated melanosis. So this is a absolutely benign condition. There is no risk of malignancy. It's very common in our country, and people who have a darkly pigmented skin, more often it is seen in them. What happens here is basically there is no proliferation of melanocytes most of the times, but there is increased pigment production from these melanocytes. You don't need to do anything about it, and they don't require any surgery or anything. Now, who will tell me what this is? Fairuz has already shown a few examples. Yes. So this is actually the most common form of conjunctival tumor in our population, and this is a benign one, fortunately. What you see here is a rather well defined, slightly elevated pigmentish mass on the bulbar conjunctiva near the limbus, and there may be one or two feeder vessels, thin feeder vessels, as you see here. And what you see here is the presence of these small tiny vacuoles or cysts within the substance of the lesion, and that tells you that this is a benign lesion, and this is known as nevus. This is a slightly larger variety of nevus, and if you are able to do an AIOS2025, you will be able to see the cysts more clearly, and if ever you are in doubt, you can resort to AIOS2025, look at the cysts, and you will get to know that this is just a nevus. So management will be covered by Dr. Honavar later on. But these usually don't require anything except observation unless the patient wants a cosmetic removal. Typical locations of nevi are near the limbus on the bulbar conjunctiva, and even the plica or on the caruncle. It's normal to have them. It should not alarm you if you see a nevus on the caruncle. It's okay. Now, sometimes the parents of a child come that this was a spot that they were seeing for a long time, but now suddenly it has become darker, blackish, and little more red. So what to do? And you remove it, and what you find is an interesting variant of the nevus, that is the inflamed nevus. So it's still a nevus, but in children, especially if they are in the pubertal age group, it may get inflamed a little bit, or children who are more prone to allergic conjunctivitis or vernal spring catarrh, those are the cases where the nevi can get inflamed, and you may have a sudden change in color and slightly more reddish appearance or more vessels. Nothing to be alarmed about. You can counsel the parents, You can observe it, give some steroids, or if still the parents are concerned, there is no harm in removing it. Now this is one type of pigmented lesion which came with a large associated cyst, and as Dr. Fairuz had already shown you one example, this was a balloon cyst kind of a variant of nevus. Another variant of nevus which is rather less common in our population, but in Western countries or in fair skinned people it can be seen, which is a patient presenting with a small pinkish or slightly yellowish type of a lesion on the bulbar conjunctiva. But what if you see typical cysts in that, that tells you again that it is a nevus and it's an amelanotic nevus. Not necessarily all nevi will be black. Remember that. Malignant transformation of a nevus is extremely rare, less than 1%. Now, if you see a nevus which has its onset in adulthood, there is a recent growth or color change and location other than bulbar conjunctiva, plica or caruncle, if they are prominent feeder vessels, if there is a recurrence after excision, so you should maybe reconsider your diagnosis and probably take these patients up for a biopsy. Now, this is a 60-year-old patient who presented with this diffuse extensive pigmentation of the bulbar conjunctiva for the last, growing steadily in size for the last 4 to 6 months. Anyone in the audience who can tell me what this is? Sorry? PAM, yes. So this is PAM, also known as primary acquired melanosis. As the name suggests, it's a primary pigmentation of the bulbar conjunctiva, meaning it's not secondary to any other cause like Addison's disease or drug induced or cosmetic induced. So it's a primary melanosis which is acquired, means it comes on later on in life and it's not present since birth. Usual age group at which it comes is the 5th or the 6th decade. You see it as a flat pigmentation of the conjunctiva which is relatively ill defined. The edges are not sharp as sometimes you may see in a nevus, and it's more flat. Now if it's on the bulbar conjunctiva, it's okay, and what you can map it properly, maybe observe it, or depending upon the extent you have to take biopsies. That will be covered later in detail. But if you see something like this lurking in the fornix, then you need to be more careful. You need to look at these patients with a little more cautious eye and not ignore this kind of pigmentation which is a recent onset, and you have this varied pigmentation in the fornix. I must biopsy these patients. This patient turned out to be PAM with atypia. Now, when you excise these lesions, the pathologist will tell you the information that you need. That is, the PAM can be of two types, either without atypia or with atypia. PAM without atypia has 0% chance of progressing to malignancy or melanoma, whereas PAM, if it is present with atypia, has almost 50% chance of progression to a melanoma. Again, in PAM with atypia, there can be high risk cases or low risk cases, and that helps you to decide your treatment about these lesions. Apart from fornices, if you see an acquired pigmentation on the tarsal conjunctiva or the palpebral conjunctiva, again that is a danger sign. So you need to be very careful. If you see this kind of an acquired pigmentation on any other site than the limbal or the bulbar interpalpebral conjunctiva, be a little more careful and have your threshold of biopsy lowered. For a very small lesion you can observe, but if it is larger than 2 clock hours, then you will have to intervene. So this is a histopath classification of PAM and risks of evolution into the conjunctival melanoma. As you can see in this chart, PAM without atypia is 0% risk to melanoma, PAM with atypia almost 46%, and then if the atypical melanocytes are located in other than basal layer of epithelium where they normally should be, then it's almost 90% risk of conversion to melanoma. And if they show epithelioid cell features, it's almost 75% risk of conversion to melanoma. So it can be pretty dangerous. So never ignore these lesions, elicit a proper history and look at the danger signs. This is how you properly map out these conjunctival lesions, especially those which are irregular, diffuse or multifocal ones. Now there are some clinical risk factors which you can keep in mind and which can tell you that this patient requires either a relatively closer observation or some intervention. If the patient with PAM is of an older age group, male patients have been known to progress more to melanoma than females if the location is fornix or tarsus. greater diameter, greater thickness, feeder vessels or an intrinsic vessels and hemorrhage. Now this lesion sometimes is confused with PAM, but if you look closely, the color is slightly different. It's not as brownish as you saw in the previous pictures. It's slightly grayish or bluish. Now why does that happen? Because this is not a conjunctival pigmentation. This is a benign lesion. This is a benign thing. It's scleral pigmentation actually, episcleral pigmentation. And in these cases, these will not progress to conjunctival melanoma, but you have to be careful, look at their dilated fundus. They may have a malignant choroidal or uveal melanoma. That is more likely in these patients. So be cautious, and you also look at the palate in these patients, look at the hairline pigmentation because they can have melanoma on other sites in the body as well. But they don't have conjunctival melanoma. This is not a conjunctival lesion. So it's important to differentiate between these two entities. This is an example of a secondary acquired melanosis, pigmentation in the fornix caused by chronic use of an eyeliner. So now this patient presented recently with a diffuse pigmentation of the inferior fornix, the medial fornix and nodule formation in the upper fornix, dark pigmentation on lid eversion. It looks something like this. So what is this, PAM or what? Yeah. So if you notice carefully, what is happening is that this patient seems to be having PAM, which might have later on progressed to melanoma. So this is how it goes. So it starts as a PAM, but in many cases it will transform into melanoma at some stage. Now if one of us is seeing this patient at an early stage and we are able to pick out PAM, pick out the warning signs and maybe excise the whole thing at an early stage, then maybe the patient would not land in a situation like this. Another patient, similar. What do you feel this is? So it has got a pigmented part, it has got a non-pigmented part. Thick, nodular. What does this look like? Exactly. So this is also another case of PAM converting to melanoma again. Another patient, similar. You have diffuse dark pigmentation of the fornix of the palpebral conjunctiva. Had these warning signs been tackled at an early stage, maybe patient's life would have been saved. This patient also had a large mass in the superior fornix when he presented. Again melanoma, patient died from metastasis. Another patient, look at this. So I can show you many examples, but what is important here to understand is that most of these cases of melanoma, as far as I have seen in my last so many years, they have all arisen from PAM. Very rarely they can arise from nevus, rarely, and extremely rarely that they arise without any primary predisposing risk factor. So as our ophthalmologist, and one of the purposes of having this IC over and over again every year is that we try to pick them up early on. None of us should make that mistake of missing out PAM at a stage where it is still manageable easily and which can seriously affect the prognosis in terms of patient's life, because these melanomas are really dangerous. They have a high incidence of metastasis. So when we see a melanoma like this, again it's better to document it properly, and one of the ways is to go by the AJCC 8th edition classification, in which T1 is the tumor of the bulbar conjunctiva, T2 is tumors of the non-bulbar conjunctiva and tumors involving the caruncle, and T3 is any local invasion like into the globe, eyelids or orbit, and T4 is tumor of any size within CNS and henceforth. And as the grade grows, so does the mortality grows and prognosis worsens. Systemic metastasis, whenever we see in these patients, usually it is lymph nodes which get affected first, then the liver, lungs may be affected, and even brain has been known to get affected. Systemic metastases are fairly common. The reported incidence is about 26 to 40% for lymph nodes, and mortality in Western literature is 13 to 38%. But I'm not sure about the Indian data, but I'm sure if Indian data was compiled, then the mortality would be far higher, because the kind of patients we see here, they come to us at a pretty late stage. They come with a pretty massive involvement, and that is a time, by that time when they come to us, they already have some sort of micrometastasis sitting elsewhere. So coming towards the end, you need to differentiate these tumors from some masquerades. Dr. Fairuz again showed you an example. Now this looks like a pigmented lesion, but actually if you look carefully, there are patches of whitish keratin on this lesion, so which tells you that this may not be a melanoma, but the keratin part shows you that this is more like a squamous cell carcinoma, which may have pigmentation in our population or a pigmented skin type person. Now this patient presented with a pigmented lesion with feeder vessels and some nodules also in that. So one of my main differentials was melanoma probably. And on excision I was pleasantly surprised. This was not a melanoma actually. This was again OSSN only. But what these nodules are, these are lymphoplasmacytic infiltrates. So you do get all these varieties. They can come in any shape and sizes. So wherever in doubt, better to do a biopsy. So in the end, to summarize, there are good, bad and ugly pigmented lesions. Nevi or complexion associated melanosis are the good ones. PAM, some of them can be good, some of them can be very bad, and melanoma is really ugly. So early identification is the key, because you want to avoid metastasis, you want to save the life of the patient at a stage where it is manageable. Once it grows into full-blown melanoma, these patients have been known to come with metastasis even 5 years, even 7 years, 10 years down the line. So best is to avoid that stage. Thank you very much.
Thank you, Dr. Vikas Menon. It was an extensive clinical, I would say an album and great case. It was definitely a learning, and as he emphasized that, getting something right at the very early stage is so important for the final outcome as far as even life salvage is concerned. It's a pleasure and honor to